projects are pre-participation in health screening. The main purpose of it is to identify and exclude individuals with medical contraindications to exercise. We want to ID those at an increased risk for injury or death. Ultimately, we don't want to disqualify anyone without compelling medical evidence or at the request of our doctors. And we want to provide informed consent forms and HIPAA policies to athletes. Our PPE is a stationary base, so athletes will begin with their medical history, then moving on to the physical examination, a cardiovascular screening, an orthopedic screening, sickle cell trait screening, ultimately leading to their hopefully sport clearance.
From here, so the medical history of the student athlete, the number one thing is going to be required paperwork. It's going to be completed by the student athlete. This medical history packet usually includes all of the items listed below. So previous medical conditions, current previous injuries, any surgeries or hospitalizations, any medications they may be on, specifically prescriptions. We need to know about any banned or controlled substances they may be taking, because a lot of them do have medical uses, but they could be disqualified if that isn't properly documented. Also allergies, menstrual history for females, and then a psychosocial evaluation. I think that's something that's growing in more recent times, just keeping track of how the athletes are feeling, how they're doing, especially in a current time like COVID. And it also needs to include an updated copy of the health insurance card. So first part, physical examination. Our main components should be conducted by a physician. A lot of times, at least at Chatham, you fill out all your paperwork. It's kind of facilitated by the athletic training staff, and then they send you into a room with the physician. Or if you have an institution like RMU, the paperwork is filled out, vitals are taken by the athletic training staff, and then it's a room with probably 3 or 4 physicians in it. Everyone's obviously spaced out for privacy reasons, but 4 athletes can kind of go in at a time, and it's all done at the site. They don't have to go to a secondary location. But the exam components mainly include height and weight, blood pressure, pulse. This can be taken by the athletic trainers, and then vision, which is gauged on a Snellen chart if needed. It's not typically a huge part of this. Normally, clearance from the athlete's eye doctor will suffice. They do a skin check, just look for any rashes or skin conditions, ear, nose, and throat. So just making sure all structures are normal, nothing is going on, checking history there. Heart and lung function, that comes with listening to heart and lung oscillations, heart sounds, lung sounds, making sure there's no crackling or cloudiness in the lung function. And then the same thing in the heart, making sure it's a nice, clean lub dub. There's no swooshing or gurgling, because that could include some kind of heart defect. Abdomen palpation, checking the organs, lymphatic palpation, so tonsils, other lymph nodes. So usually tonsils, your appendix, your axillary lymph nodes, things like that. And then maturation index. So this is just making sure the athlete is progressing as they should. So in college, if you're on a Turner scale, you should usually be at the level 5, which is your full grown, but that may differ if you have some underlying condition.
So our neurologic evaluation will be conducted by a physician or by a designated athletic trainer on the physician's discretion. Components of it is a mental status evaluation. This will primarily be conducted by just a physician talking with the athletes, determining how they usually are at a normal level, a motor function and balance, which is testing. Usually the physician will have the athlete push and pull against their hands just to test their strength and their balance. A sensory exam, so going through dermatomes and myotomes of the patient. Reflex testing, this is typically done with a neurological hammer, testing the patellar reflex. Physicians feel so they can be inclined to test other reflexes within the patient. Go into a cranial nerve evaluation, so a patient will go through and test the 12 cranial nerves. And a coordination exam, a physician will test balance and walking just to see how an athlete moves. Student athletes at this portion will also complete the concussion baseline test to provide a baseline measurement for them if they so get a concussion during their season.
Next, we have the cardiovascular screening. Now, this obviously begins with pulse, blood pressure, and we have our stages of blood pressure. So normal, 120 over 80, can be much lower for athletes who are in shape or trained athletes. Elevated is considered 120 to 129. Stage 1, hypertension, 130 to 139 over 80 to 89. Stage 2, obviously over 40. 140 over 90, and then a hypertensive crisis is anything 180 over 120, which if I ever came in with that, we'd probably refer them immediately because that's not right. I already talked about the heart oscillation, so there's 5 points of contact that they take. The first one is typically right side between the first and second rib, the same location on the left side, and then they go through the bicuspid mitral valves. All of those, making sure, like we talked about, there's no gurgling or it's just a clean, loved up sound. An advanced screening, so this becomes more evident, especially in the time of COVID. So anytime an athlete has COVID or there might be some abnormal findings in the exam, they will be sent for an echocardiogram. So this is an ultrasound of the heart in real time, and it just shows you the heart structures, the valves, things opening and closing, and if they should be doing it in a timely manner. The diseases we typically find with an echocardiogram are hypertrophic cardiomyopathy, which would disqualify athletes from participation, coronary artery disease, any other structural abnormalities. So if you have a deviated septum or your septum hasn't closed all the way, which is actually a lot more common than we think. So between your atria, there's a little hole. It's supposed to close whenever you are born, when you take your first breath, but that isn't always the case. That becomes a problem because if blood starts to leak through, that can throw a clot and lead to stroke. And then obviously clots is our last one. So for the orthopedic screening, so this one is basic, and obviously it's done by the physician, but athletic trainers, we do these all the time. So you have active and passive range of motion testing, just making sure they can move within their own range of motion and how far we can take them. Strength testing, which we talked about earlier, and that's just testing the different muscles, things like that. And typically we strength test areas of previous injury just to make sure things are bilaterally equal. If not, we note them, and that's something we need to either work on before they can get full participation or something just to keep in mind. And then finally, special testing for just joint stability and previous injury.
So athletes will then be required to go through sickle cell trait screening. They will be required to produce blood work. This test identifies the type of hemoglobin present. Normal hemoglobin is hemoglobin A, while abnormal is hemoglobin S. And this is NCAA mandated as of 2010. Athletes may provide any of the following: a blood test, proof of prior testing, or the signing of a liability waiver, which in turn will allow them to participate without having sickle cell trait screening.
And finally, we just go to some disqualifying conditions. So the most common ones for contact sports are the anti-atlantoaxial instability, any kind of carditis, so inflammation of the heart, having one of a major organ that has two, so for instance, one kidney, and then an enlarged liver or spleen.
Determined on a case-by-case basis is detached retina, hypertension, musculoskeletal disorders, seizure disorders, pulmonary insufficiencies, skin infections, history of head or spine trauma, an absent testicle, congenital heart disease, or dysrhythmia. So what goes into disqualifying an athlete from play is you need to answer 5 main questions. Does the condition pose an unacceptable risk or place the athlete at increased risk for further injury? Does the condition place other participants at risk for injury? Can the athlete safely participate with treatment? And can limited participation be allowed with treatment or while treatment is being completed? And the last one is if clearance is denied for certain sports or sports categories only, which activities with participation will be deemed safe for the athlete? Ultimately, disqualifying an athlete from participation will not be done unless advised by our physicians or with medical evidence as a whole.